Good afternoon, everyone. I hope you're enjoying this day. Let me just make a quick comment that we do have an amazing virtual exhibit hall that's open. We have representatives there that are looking to speak with you. You are also able to select literature, download it, and it will be emailed directly to your inbox. So please, please, please take advantage of it. Also, I want to thank the many people who are hashtagging and sharing all of this great information in social media. This is giving folks a taste of what's available to them through the Black Health Matters Summit. So we thank you for that. Now I'm going to introduce our next panel, which is Heartlinks presents Women and Heart Disease. And according to the American Heart Association, heart disease is the #1 killer for all Americans, and stroke is also a leading cause of death. The good news is African Americans can improve their odds of preventing and beating these diseases by understanding the risks and taking simple steps to address them. So this session is actually sponsored by the Eastern Area region of the Links, and we're delighted to have the Eastern Area Director with us and Dr. Anjanette Ferris-Senatus, who are going to talk about heart disease and specifically as it impacts women. I am going to read the bios and then they will start their wonderful presentation. And I also have to give a shout out that I'm also a member of the Links and also our producer, Deidre Tate. So we have a sister circle here. Shuana Tucker-Sims is Chief Talent Officer for the Connecticut State Department of Education. In this capacity, she has oversight of the Bureau of Certification and the Bureau of Educator Evaluation and Support. Her ultimate goal is to develop all educators to their fullest potential, specifically in the areas of equity and diversity, while ensuring educational excellence for all students. She earned her PhD in educational policy from the University of Illinois at Urbana-Champaign, a Master's of Public Administration from Louisiana State University, and Bachelor of Science degree from Xavier University of Louisiana. Dr. Anjanette Ferris is a cardiologist and an assistant professor of medicine in the Division of Cardiology at the Pat and Jim Calhoun Cardiology Center at the University of Connecticut Health Center. She is the former director of the Lipid Clinic and past co-director of the Women's Heart Health Program at the Pat and Jim Calhoun Cardiology Center. Her areas of expertise include clinical cardiology, cardiovascular disease prevention, women's cardiovascular health, dyslipidemias, and healthcare disparities. And now I introduce you to Dr. Ferris and Dr. Tucker-Sims. Thank you.
Thank you so much, Rosalind, for having us, and good afternoon, everyone. I bring you greetings on behalf of the officers, leadership team, and over 4,500 members in 80 chapters of the Eastern Area of the Links Incorporated. It is a pleasure to be here at the Black Health Matters Winter Health Summit 2021. The Links Incorporated was founded almost 75 years ago in Philadelphia. Against the backdrop of a segregated America, they sought to create a network of friends that would leverage their collective talents, influence, and resources to make a difference in the lives of the people and communities of the African diaspora. Today, that idea has blossomed into an organization of 16,000 professional women of African descent in 292 chapters in the US, the Commonwealth of the Bahamas, and the United Kingdom. Black Health Matters encapsulates the criticality of today's gathering, because the first and most fundamental step in valuing, sustaining, and advancing Black lives is to do the same for Black health. In the Links, one of our programmatic focus areas is health and human services. It was established in response to the chronic health disparities that persist in Black communities. When it comes to health, the heart matters. Nothing is more literally or figuratively central to overall wellness than the heart. Heart disease is especially prevalent in our community and the number one killer of African American women. The current global pandemic has served to highlight its importance. Cardiovascular disease is an underlying condition which can potentially make one more susceptible to contracting COVID 19 and lead to more serious impacts once it occurs. Preliminary studies also indicate that COVID 19 has the potential to cause lingering impacts on cardiovascular health even after recovery. As Links, one of the things we do in February is Go Red to promote cardiovascular health. It is both a reminder to our members and a public acknowledgement to our communities about the need to proactively manage cardiovascular wellness. Through our Heartlinks National Signature Program, we implement activities throughout the year, such as our Walk for Healthy Living, childhood obesity prevention, and cardiovascular risk reduction programs. Heart health is something we cannot afford to ignore, especially as Black women. I am pleased to introduce the expert for our discussion on women and heart disease. Dr. Anjanette Ferris-Senatus is a cardiologist and assistant professor of medicine at the University of Connecticut Health Center. She is also a sister link who leads the Greater Hartford chapter in Connecticut. Please join me in welcoming Dr. Ferris-Senatus.
Thank you so much, Dr. Tucker-Sims, for your kind introduction. And thank you, President Daniels, for allowing us the opportunity to participate today. Thank you also to event producer Deidre Tate for allowing us to participate as well. We are excited to be here, and I am particularly excited to be participating today. I am going to discuss women and heart disease. And as was already stated, heart disease is the number one cause of death for both women and men in the United States. It is a leading cause of death, not only in the United States, but globally. Unfortunately, since 2019, heart disease has surpassed all other causes of death globally. So in the past, there were countries where infectious diseases was the number one cause of death, not so anymore. And sadly, this crown is now worn by all of us throughout the world, so we must try to combat it. Nearly 1 in 5 women will die of cardiovascular disease. Approximately every 36 seconds, someone dies of cardiovascular disease. So as we gather here for this session, 50 people will die. 53,671 Black women die each year of cardiovascular disease. So it disproportionately affects our community, and we'll look more into those statistics shortly. So when we describe cardiovascular disease, we refer to disease of the heart and also disease of the vessels within our body. And I just wanted to clarify heart disease a bit more, because we hear heart disease, and what does it mean? So there are several types of heart disease, and what we focus on more is coronary artery disease, which is disease of the arteries that supply the heart. And so if you develop blockages in these arteries, then it will lead to sometimes heart attack, which we're going to try to avoid, and that's why we're all here. But coronary artery disease is a big component of what we refer to when we speak of heart disease. Heart failure, the muscle the heart is a muscle, and so this muscle, works from the time we're in our mother's womb, over time we can develop heart failure depending on other diseases that we may have. So heart failure refers to kind of the failure of the heart muscle. The heart muscle can become dilated or enlarged and not function properly, or it can become thickened. If we have high blood pressure that's not well controlled, it becomes thickened and stiff, and so it doesn't have a elasticity as it had once, and so that can lead to heart failure. Congenital heart disease, if you hear that term, that refers to heart disease that we're born with. And thankfully, over the past decades, we've been fortunate enough to make great strides in congenital heart disease, and individuals are living longer who were born with heart disease. And arrhythmias, in addition to the heart being a muscle, it's also an electronic organ. If we look at it that way, it conducts electricity. So we have what are called pacemakers within our heart. And if there's an abnormality of our rhythm, that's why we're able to look at our heart rhythm on an EKG or an electrocardiogram. If there's an abnormality, we refer to this category as arrhythmias, such as atrial fibrillation. So just wanted to clarify that, but we're going to focus mainly on coronary artery disease today. So just want to give a little bit of a historical perspective. Heart disease was viewed as a disease of men actually not too long ago. So there was a conference in the 1960s entitled, "How Can I Help My Husband Cope with Heart Disease?" So really, it has not been that long that we now recognize that not only is it the #1 cause of death for men, but also for women. And there was a dietary pamphlet entitled "The Ways to a Man's Heart," what kind of dietary foods that we can prepare in order to keep our man's heart healthy, without the focus on our heart. And so we have come a long way, and just realizing this is quite recent. So in 2003, I conducted a study along with the American Heart Association and with Dr. Lori Muska, who was my mentor at the time. And we looked at the perceived leading causes of death for women. And if we look at this graph, in 1987, the American Heart Association conducted a similar study, and only 30% of women at that time were aware that heart disease was the #1 cause of death. By the time we did our study, 46%. So it was an improvement. However, we were still not at 100%. So we still have a way to go and had a way to go at that time. And oftentimes women will refer to cancer, or specifically breast cancer, as the #1 cause, not knowing that heart disease is. So we looked at the study in 1997, and 30%. My study, we found that 46% of women knew heart disease was their #1 cause of death, and there was an improvement. By 2012, the study was conducted again, and at that time, 56% of women were well aware heart disease was their #1 cause of death. And the American Heart Association and the National Heart and Blood Institute, they kind of ran campaigns such as the Go Red for Women campaign that was initiated around 2003, 2004, increasing awareness of heart disease among women. So many of these campaigns helped to increase the awareness. Unfortunately, the study was recently conducted, and in 2019, we see a dip. Only 44% of women were aware that heart disease was their #1 killer. So we want to be at 100%. So we really have a lot of work to do, and we have to redouble our efforts in increasing awareness. And there's also a disparity within women, within groups of women. So if we look here, the blue bar represents white women, the pink bar represents Black women, and the green bar represents Hispanic women. And we see there's, even within women, each of these years, there's a disparity, with Black women being less aware that heart disease is the #1 killer, and heart disease affects our community at even higher percentages. So we still have a lot of work to do. This is a map from the Centers for Disease Control, and really showing, reflecting the clustering of heart disease, specifically in the Southeast region of the United States. And it is not an accident that the high propensity of heart disease correlates with a higher propensity of obesity and diabetes. So many of the risk factors that we'll talk about shortly that accompany heart disease. So the traditional risk factors for coronary artery disease include high blood pressure, diabetes, elevated cholesterol levels, and we'll talk about each of these in a little bit more depth. Tobacco use, hopefully none of us are smoking at all, and we'll talk about the detrimental health effects of tobacco use. Family history, we can't change our genetics, so some of us have a propensity to develop heart disease, and so we have to even work harder to help reduce our risk. And also advanced age, as we get older, our heart disease risk goes up. Obesity and physical inactivity, which was not kind of traditionally looked at as risk factors, are now included as risk factors for heart disease. So we want to work at all of these simultaneously. Let's focus on hypertension. Nearly 1 in 3 adults has hypertension, so a very high prevalence in the United States. So hypertension may lead to, we spoke about a little bit earlier, heart failure. So again, hypertension, blood pressure not being well controlled, our heart can become thickened and not function properly, and that's what we kind of determined to be heart failure. Coronary artery disease can lead to blockages within the arteries of the heart. Stroke, which is another leading cause of death in the United States, and kidney disease. And so we don't want any of these if we can avoid it. And so really controlling our blood pressure is key. Hypertension, or high blood pressure, we refer to as the silent killer, because many of us don't know if our blood pressure is elevated. And that's why it's indeed important to follow up with your healthcare provider, and know your numbers is another key message that I want to get across. Know what your blood pressure is, and that's going to be key in helping to manage it and make sure it's under control. So this is a blood pressure classification chart. We try to target a blood pressure, a systolic blood pressure, which is our top number of 120 or lower than 120, and our diastolic, which is the bottom number, over 80. So 120 over 80 is the number you want to keep in mind You want your blood pressure to be 120/80 or lower to be in normal range or optimal range. Elevated blood pressure, if your systolic blood pressure is between 120 and 129, it's an elevated category. In the past, we never considered these numbers to be elevated, and now we do. And I'll show you a quick study to inform you why we changed those guidelines. Stage 1 hypertension, if you have a systolic blood pressure of 130 to 139 or diastolic blood pressure of 80 to 89, you're in stage 1 hypertension, and you really should be modifying your lifestyle, reducing your salt intake, exercising to try to bring your blood pressure down before going on medication if needed later on. And stage 2 hypertension is a blood pressure of 140/90. That's really quite high. And actually in the past, that used to be our target number. We used to target a blood pressure of 140/90, but we no longer agree that that number is the target. That's very high. And I'm going to show you shortly why so. So there was one study conducted, the SPRINT trial of many, and it looked at 9,000 individuals at increased risk for cardiovascular disease. These individuals did not have diabetes, but were at increased risk for other reasons. And they were randomized. They were put into two groups. One had intensive blood pressure control, getting that systolic blood pressure to 120. And the other group was less intensive control, getting the blood pressure to about 140, the systolic, the top number. The primary endpoint, what was looked for in the study was myocardial infarction or heart attack, stroke, heart failure, or death from cardiovascular disease. So these are endpoints. These are points you don't want to achieve. And so this is what the study looked at. The trial actually was stopped early after 3 years due to significantly lower rate of primary endpoints in the blood pressure in the group that had the blood pressure well controlled. So individuals who had their blood pressures controlled to 120 or systolic blood pressure controlled to 120 or less achieve these endpoints, were less likely to achieve these endpoints, meaning were less likely to die of cardiovascular disease, less likely to have a heart attack, less likely to have a stroke. So with that data and also other studies that were conducted, that's what led us to drive those numbers down to really target an optimal blood pressure of 120/80. This is a chart looking at blood pressure, the incidence of cardiovascular disease in women over time. So this is the incidence of cardiovascular disease. And this is a kind of numbers in years, 14 years. And if we look here, if the high normal, which is that in the past we thought of as 140 systolic, over optimal 120, we see that over time, women in this category had less cardiovascular effects, much lower. So really, that's why we try to target lower numbers now. So when you go in to see your healthcare provider, you want to go in with a pen and pad. You want to make sure you write down your blood pressure. You want to also monitor your blood pressure as your healthcare provider is as well. And we'll talk about ways to reduce your blood pressure with exercise and with dietary modification. Cholesterol is another risk factor for heart disease. I'm just going to briefly go through some numbers. The guidelines have changed, and so now we look at kind of individual risk to determine what your cholesterol goals should be. But just kind of a rough estimate in the past, we used to, you really want to try to target a total cholesterol of less than 200, an LDL cholesterol level of less than 100, ideally less than 70. An HDL in the past, we used to want the HDL cholesterol levels to be greater than 40 for men, greater than 50 for women. That's what's referred to as good cholesterol. And so I always like to think of healthy. So good cholesterol, you want a nice high HDL cholesterol. And triglyceride level, the target really, we want to have that number to be 150 or lower. So these are kind of rough estimates of where our number should be. Again, you want to ensure that you have your cholesterol levels checked, ideally while fasting, not having anything to eat prior to going in to see your healthcare provider. And then we can have a rough estimate as if we have to indicate more lifestyle modifications in order to help reduce cholesterol level. Because the one thing we want to try to do and emphasize is we want to try to modify our diet and our physical activity in order to bring some of these risk factors under control. Oftentimes we can do everything correctly and we may still need medication, but number 1, 2, 3 is physical activity, dietary modification to help improve our standing. So diabetes, there was a wonderful session on diabetes earlier. Inappropriately high blood glucose or blood sugar secondary to either a deficiency of insulin or insulin resistance. And your body doesn't kind of process sugar that well. So the prevalence of diabetes has increased by 54% between 1994 and 2002. Prevalence continues to increase. There have been kind of fluctuations, but really overall, As our obesity rates go up, our diabetes rates go up as well. So really quite an epidemic in our country now. And so diabetes, there's type 1 and type 2. I won't go too much into the types, but the main thing is kind of screening and knowing where we are as individuals in our own profile. So what we want to try to do is when a patient comes in, we want to try to kind of do some blood tests, check a fasting plasma glucose level, and that level should be less than 100 milligrams per deciliter. So we want to kind of ensure that it's under that. And if you come in and you're fasting and your numbers between 100 and 125, you may have pre-diabetes, impaired fasting glucose intolerance. This is a group where we really try to target lifestyle modification to help bring those numbers down, because that can often help prevent the onset of diabetes. If your fasting plasma glucose is greater than 126, that may indicate diabetes. You may do further testing. And hemoglobin A1C is another number that we look at. It tells us what your sugar or glucose number is over the past 3 months or so. And normal, we want to really try to get to less than 5.7. So these are some of the tests that your healthcare provider may do in order to determine if you have diabetes. If you already have been diagnosed with diabetes, it's still important to keep your glucose levels under control to prevent some of the diseases that can be secondary to the onset of diabetes, such as coronary artery disease. So tobacco use, we know we should not smoke for many reasons. It leads to cardiovascular disease, it leads to lung disease, not good for us at all. And we want to really, if anyone is a smoker now, if I can get one thing clear, we want to try to stop smoking. It's sometimes hard to do on your own, and if you need help, your healthcare provider will work with you to help reduce, to eliminate tobacco use. That's the one thing we can do to significantly reduce our risk. Smokers are 2 to 4 times more likely to develop coronary artery disease than non-smokers. Smokers are 2 to 4 times more likely to develop a stroke. And life expectancy for smokers is lowered by 10 years. So it really it takes a decade off your life. So anything we can do to help eliminate tobacco use, we want to really strive for. So obesity, nearly 67% of women in the United States are overweight or obese. And this number has consistently risen over the past decade. Among African American women, 80% of us are overweight or obese. So we really have a lot of work to do in this area. And hypertension is 3 times more common in obese individuals. So obese women have double the rate of developing heart failure compared to women of normal weight. And when we refer to obesity, body mass index is kind of a rough gauge of what our height to weight ratio is. There is some discrepancy. Does it apply to all groups? But it's a crude measurement. So we want a body mass index of between 18.5 to 24.9 for normal weight. An overweight category is 25 to 29.9, and obese is a BMI over 30. We also look at waist circumference. Waist circumference, we try to kind of have a waist circumference of 35 inches for women and 40 inches for men. Again, different ethnicities, different groups may carry adiposity or fat in different areas. So again, crude measures. I just wanted to briefly touch on heart disease and COVID-19. As we know, COVID-19 primarily affects the respiratory tract in the initial phases. However, it can progress to severe systemic illness. And risk factors for heart disease that are also comorbid conditions for severe illness with COVID-19 include many of those which we've already spoken about: high blood pressure, diabetes, advanced age, and obesity. So underlying cardiovascular disease is associated with poor outcomes with COVID-19. So those of us who have heart disease, we have to be even more cautious during this current pandemic. However, COVID-19 may also lead to cardiac injury. So cardiac injury is noted in 20 to 30% of hospitalized patients with COVID-19, and it is believed to contribute to 40% of deaths from COVID-19. So there's a strong correlation between the two. All the more reason why we should, try to be quite healthy and try to even modify our lifestyle even during this pandemic. So heart attack symptoms, what are they? Chest pain is the number one symptom we hear of. Pain in the jaw, one of both arms, neck, shoulders, shortness of breath. Some people can develop nausea, lightheadedness, fatigue. Women can often present atypically or differently. So we may not have the chest pain, we may just have shortness of breath or perspiration, very atypical symptoms. So we always want to listen to our bodies. Anything new that develops, we want to ensure that we touch base or visit our healthcare provider even it's during this telemedicine time, we want to ensure that we have a constant communication. This is just a quick diagram of a blood vessel. And here we have, oops, sorry. Here we have what we call the lumen of the blood vessel. If you take a blood vessel and cut it in half, this is a cross section. And so we see here a healthy blood vessel. It has a little bit of fat in the vessel wall, but this is what's called, well, not quite healthy because there is a lot of fat in the wall, cholesterol buildup. But this is a ruptured plaque. And what happens is blood forms, a blood clot forms in that vessel, and you block blood flow. And so this is part of a coronary angiogram. This is a blood vessel. This is what we see when we do an angiogram or cardiac cath. This is a blockage in one of the blood vessels. It's not 100% blocked. This is kind of what we call a stenosis because you see some blood flow afterward, but this is what we want to try to avoid. And this is actually a heart muscle cut cross-sectionally. And we see here, this looks different than this healthy heart. This is part of the heart that's died. This is what happens when you have a heart attack. That part of the heart is oxygen starved and it dies. And so getting to the hospital in time is critical because we want to avoid and reduce the amount of heart muscle that dies. There are gender differences between men and women. Women, again, we talked about, may have atypical symptoms. Women often develop coronary artery disease at an older age. Oftentimes when we hit menopause, our estrogen levels go down and we may be at a higher risk. We may have diseases, oftentimes have disease in the smaller branches of the arteries, and studies reveal that we have a higher mortality. So 23% of women compared to 18% of men will die within 1 year of having a heart attack. 5 years after a heart attack, 47% of women will die compared to 36% of men. So what is the reason for this disparity? There are many reasons. Sometimes, again, we are always taking care of everyone else. We're taking care of our children, our husbands. We may present later at a later stage in our disease. And oftentimes we have comorbidities. We have heart disease at an older age, but there may be some treatment differences. There was a study conducted with over 78,000 patients in 420 hospitals in the US. And after an acute heart attack, women were less likely to receive aspirin therapy, beta blocker therapy, or timely perfusion, when we can go in, do a cardiac cath, see the vessel that's blocked, and we can open it up with a stent potentially. And so women were less likely to receive these treatments. So we still have a lot of work to do also within the healthcare community. Racial disparities also within cardiovascular disease. So 58.8% of Black women over the age of 20 have cardiovascular disease or have some form of cardiovascular disease, compared to 42.7% of Hispanic women, white women, and Asian. So again, we are overrepresented in this category, and this is the category we don't want to be overrepresented in. And so we really have to do a lot of work in order to prevent heart disease. The good news is that nearly 80% of heart disease is preventable just by what we do. Lifestyle modification. We want to, with the American Heart Association Life Simple Sevens, we want to focus in on improving our health behaviors, becoming active, exercising for at least 150 minutes per week, usually 30 minutes 5 times a day, eating a balanced diet, maintaining a healthy weight, as we spoke about, eliminating tobacco use. And if we already do have high blood pressure, we want to manage our blood pressure. If we have our diabetes, we want to make sure our sugar levels are under control. And if we have high cholesterol levels, we want to make sure our cholesterol levels are controlled. Oftentimes we can do that just with weight loss or with dietary modifications, which include exercise as well in achieving the weight loss. However, that may not be enough at times. And so we may need medications, and it's important to take them if we do need them, because we really want to prevent the long-term effects of high blood pressure, diabetes, and elevated cholesterol levels. Primary, secondary prevention, diet rich in fruit and vegetables, whole grains, limit your saturated fat, and again, 150 minutes of moderate intensity physical activity each week will help you to reduce risk, not just of heart disease, but of certain cancers as well. So really staying active is quite important. And we talked about the importance of maintaining a healthy weight. So the important messages today: focus on prevention, do lifestyle modification. If you're not exercising, get started today, walk. You know, don't become intense with your exercise immediately, but just a calm stride, building up 10 minutes a day to 15 to 30. And eventually you'll be there, and it'll become like waking up. And so I like to think of it as, you know, you wake up, you brush your teeth, you get ready, you take your shower. You want to make sure that you include exercise and take care of yourself as well. Know your numbers and follow up with your healthcare provider. and of course, recognize the signs and symptoms of a heart attack and call 911 immediately. We found that during COVID, many people are staying away from hospitals. However, it's important to get there in time. Again, you saw that image of the heart muscle that's been starved of oxygen. We want to try to avoid that becoming pervasive throughout the heart, because that can lead to heart failure. And I thank you so much for the time, and appreciate being here today. Thank you.
Thank you, Anjanette, for that informative and engaging presentation. I think we all learned quite a lot. I've been asked to field question and answers for you, and there are quite a few questions in the Q&A box. The first one, how does stress test determine the condition of the heart?
Great question. So a stress test is a test that we do in order to assess whether you may have underlying coronary artery disease, or if you have any underlying blockages in the arteries of the heart. So a stress test, we can do it several ways. We can do it by a treadmill. And oftentimes this is determined after, for example, if you're coming in with new symptoms such as chest pain or shortness of breath, your healthcare provider may order a stress test. You walk on a treadmill, and then we try to get your heart rate up and try to essentially stress your heart. And that will reflect in the EKG, and we'll see if there's any evidence of blockages. And so that helps us determine. We can tell by the EKG, and oftentimes we can do it with imaging. Some people may not be healthy enough to walk on a treadmill, and we can do it just with imaging. And that helps us to determine if there are any blockages in the heart that we have to investigate further.
Thank you. Next question. I know hypertension is silent, and it has been elevated when I didn't feel it, but there have been times when I felt it was elevated because I was stressed, and it was.
Stress is not good for us, but we can't avoid stress. We can't escape it. And so it's what we do to help get through our stressful period. And having a support group is extremely important, but ensuring that you follow up with your healthcare provider, because some people, a lot of times we don't feel if our blood pressure is high, but some can feel it. You know, it may develop a headache, or if you know you're stressed, your body's going to react in that fight or flight mode. And so your blood pressure is going to go up, your heart rate is going to go up. And if you're constantly stressed, that is quite detrimental, because some people, their blood pressure can remain elevated. So relaxation techniques are important, but what's important as well is ensuring that you have your blood pressure checked, because it can be silent. And if it is elevated, we can work on dietary modification and exercise to help bring it down. But if it's extremely elevated, we want to try to work with that lifestyle modification, and sometimes medications are needed. And if you are on medication, don't say, well, I'm feeling well, I'm not going to take them anymore. You take them, because we want to avoid those are horrible things that can occur if hypertension goes unchecked.
Okay. Next question. Could you repeat the healthy numbers for cholesterol levels, please?
Sure. So, and I just want to preface that by saying the guidelines right now are very individual. So you have to sit down with your healthcare provider, go over your risk, and to see where your number should be. But as a rough estimate, what we went with in the past, total cholesterol, we want to be under 200. LDL or bad cholesterol, we want, right now, we really try to target it low. So we want that to be about 100, ideally under 70. And that can, differ for different individuals. And HDL, your good cholesterol, again, these are old numbers, but these are kind of a rough target if you want to keep in mind. HDL, healthy cholesterol, you want that to be above 50 for women, above 40 for men. And the triglyceride level, you want that to be under 150 or lower.
Okay. Our next question. If you are currently taking blood pressure medicine and physically active with consistent good blood pressure numbers, how can I get off the blood pressure medicine?
That's a great question, because the good news is, as I mentioned, a lot of times if we just lose weight, if we lose just 7% of our weight, so if we're 200 pounds, then, we just lose about 14, 15 pounds, that can have a dramatic reduction, not only in just our blood pressure, and even it doesn't even take that much. We just lose a few pounds. So some people may struggle and say, well, it's not really working for me. Yes, those few pounds make a difference. That lowers the blood pressure. It even lowers diabetes risk. Sometimes we can lower our risk for developing diabetes by 50% just from weight loss. So it's important to continue to do dietary modification and also medications. And oftentimes, if you're making a lot of lifestyle changes, you may be able to come off those medications eventually, and you may be able to stay off of them. So it's important to, lifestyle modification is key because you can, every medication has a side effect, but we look at the risk benefit. So the benefit of having your blood pressure control outweighs the risk of some of the side effects. But it's important to incorporate lifestyle modification because you may be able to come off medications as well, or you may be able to come off, the one that you're on, or if you're on multiple, you may be able to bring it just down to one.
Okay. A technical question. Tech has asked that you stop screen sharing.
Oh, sorry.
And secondly, another question in the Q&A box, will the presentation be available for all to see? And I do know that we will upload the presentation to the Eastern Area Links booth after the session concludes. The next question, it says, my mother is 87, Alzheimer's patient, 1 stroke in 2018. Her doctor says 140/90 is acceptable for her. Is this true?
So that's a great question, and I'm happy that it's come up. So we may be able to tolerate slightly higher blood pressures in elderly patients, and it really depends because sometimes what happens as we age, our blood vessels become quite stiff. And so sometimes that blood pressure that we obtain in elderly patients, may not truthfully reflect what's going on. And so sometimes we may tolerate a slightly higher blood pressure in some individuals. So that's why I said it's quite, it's very specific, and it's important that you meet with your healthcare provider. And sometimes for elderly patients, especially if they're on multiple medications, being on multiple blood pressure medications may lower their blood pressure too low. And so there can be medication interactions, but yes, that's a good question. Sometimes we may, especially for elderly patients, tolerate slightly higher blood pressures for different reasons.
Okay, next question. This is a long one. I lost both parents to heart disease. I have it too. I have a racing heart. I had a heart attack 25 years ago. I have high blood pressure. I monitor it daily. It goes up and down to 195/95 or 99, or sometimes 117/85. I don't know what to do. I go to my cardiologist often. I'm on 2 different medications for blood pressure plus 1 for my racing heart. I am obese. I feel like a walking time bomb. I want to live. I'm trying to eat healthy. Is there a clinic or someone who can follow me to help me?
Well, first I want to say that I'm so sorry about the loss of your parents. It's never easy, no matter how long it's been. And it's important that you have focused in on your own health. Definitely, there are red lights flashing at me. I think it's important, one, to start with your primary care provider, or if you already have a cardiologist that you're working with, really go in and sit down again with paper and pad and say, listen, we've got to make some changes, and I've got to get on the right track. You really want that blood pressure not to fluctuate, up and down. Heart rate, sometimes that can fluctuate up and down, but we really want to try to get things under control. We can work on many things, but one of the things we want to ensure is that our blood pressure immediately is under control and our heart rate's under control. And then after that's under control, even if it has to be with increased or changing in doses of medications, then we want to work on lifestyle and working. A lot of times we can work with the hospital or healthcare provider who has someone who focuses in on lifestyle, and we can work on and trying to get those numbers down. But we can touch base afterwards, and I'll be happy to share what I know and to see where you live, to see if I can plug you into a place that focuses in on that as well. And I wish you all the best of health and improvement in your health.
There's several questions, Anjanette, about the waist. One person has asked if you could repeat the desired stomach measurements, and then subsequent to that, is there a correct way to measure the waist? Is it over the hips or above the navel? And is your waist size an indicator of developing heart disease?
So good questions. I know there's several parts to it. Waist size. So your first question, 30. We try to target a waist size of 35 inches for women or lower, so 35 or lower, and for men 40 or lower. Again, it's crude. People are built differently, so it's just kind of a crude measurement. But adipose tissue or fat around our abdomen is the worst. It is really linked to higher risk for a lot of the diseases that we talked about. It is really kind of the worst place to carry fat. And we, also think that it may be even more metabolically active. And we know inflammation is not good. So we want to really try to reduce that. I lost track of the questions. I know there was the size of the waist.
Do you measure above the navel or closer to the hip area?
So I would say around the navel area. So away from the hips, we want to try to get it around kind of our abdomen area. So kind of around the navel area, close to that area. And another part, I think there was another part.
I think that was it. I think you answered all three for those. The next question, does vaping have the same effect as tobacco?
So we do not like vaping at all. So, any tobacco products are going to be a detrimental to our health. So we recommend against vaping. We recommend against, smoking traditional cigarettes, all quite bad for us. So really try to avoid it. And unfortunately, some of the younger kids are may kind of, try it, and it's just none of it is good for us. We try to avoid it.
The next question, please explain, and I'm not sure if I'm pronouncing this correctly, ischemic heart disease.
Mm-hmm. You pronounced it correctly. So ischemic heart disease, really it's heart disease. We kind of looked at those categories on the first slide, coronary disease. So it's focusing on coronary artery disease or blockages within the arteries of the heart. So ischemic or ischemia means decreased flow or decreased oxygen in certain parts of the heart. So when we look at ischemic heart disease, we're really talking about coronary artery disease.
Okay. Please discuss aortic aneurysms. I have a 4-centimeter aneurysm on the ascending coronary artery and want to think about it the right way and be certain that I get the proper treatment.
Great question. So again, another reason why we want our blood pressure control. So the aorta is a very large vessel in our body, and it gives off all the feeder vessels. It gives off all the branch vessels to our body. And so a lot of times if we have elevated blood pressure that's not well controlled, or if we have a family propensity, we may develop an aortic aneurysm, which is kind of an outpouching of the wall of the artery. That can be quite dangerous because it can rupture, and a lot of times that can be fatal. However, it depends on where the aneurysm is. So some people can live with a aortic aneurysm. If it's not too large, we watch it, monitor it closely. If it gets to a certain size, we may need to repair it. But blood pressure control is quite important. And the aorta is one vessel, and then there's the coronary arteries. I heard that in there as well. The coronary arteries are the arteries that supply the heart. They are branches of the aorta, which is the large vessel. So I'm not sure which one it is, but either one, you want to ensure that you're being monitored.
Okay. Are you finding that COVID-19 patients may develop heart disease?
Yes. And so even young patients. So even young patients who develop COVID-19 may develop it can be transient effect of the heart. As I mentioned, about 20 to 30% of patients who are hospitalized with COVID-19 have some form of cardiac involvement. So you may develop what's called kind of a myocarditis or an inflammation of the heart. And so we have to monitor it closely. So yes, you can develop heart disease. The good news is that some of that we can see reversal in that. But it's important, again, to be monitored. Even if you're completely asymptomatic and have COVID-19, you want to make sure down the road, when it's safe to do so, you follow up with your healthcare provider, and they'll ask a series of questions to ensure all things are okay. Specifically with young individuals who are athletes, that's quite important. If you develop COVID-19 and you have an athletic child, oftentimes, if they were very symptomatic with COVID-19, and if they're an athlete, oftentimes their healthcare provider may want to do some further studies to make sure it's safe for them to go back to their sport.
Okay. Could you kindly repeat the numbers for total cholesterol, LDL, HDL, and triglycerides?
Again, these are kind of old numbers because the new guidelines say that they're kind of independent and specific to each person, but they're numbers that we still look at. So if you wanted to have a general gauge, total cholesterol less than 200, an LDL or bad cholesterol less than 100 ideally, or less than 70 for some of us who have, let's say, diabetes, we want to get that lower. HDL, which is your healthy cholesterol, we want above 50. We want that number to be as high as possible. We want that above 50 for women, above 40 for men. And triglyceride level is, we want to be under 150, but it's going to be very specific to each individual depending on what our heart disease risk is. Your doctor may allow you to be a little bit higher, or force you to be a little bit lower, depending on where you are on that risk scale.
Okay. How often should a patient get an EKG?
Good question. So EKGs are not routinely done. You know, if you have a full physical, oftentimes it's done. If you are completely asymptomatic, not having any symptoms, you're feeling fine, you're active, usually your doctor won't, do it routinely. But if you do have underlying heart disease, oftentimes in the office we'll do one if a person already has heart disease, maybe once a year, but it's very individual and it's not something that is automatically undone. But obviously, if you're coming in with new complaints such as shortness of breath or chest pain, we get the EKG done to see if there's any change in your old one. So at least we get a baseline during your physical, so we know if there are any changes in the future, we can compare them.
What test should you ask your oncologist to perform after chemotherapy and radiation, particularly after breast cancer treatment?
Good question. So some chemotherapy agents can lead to a cardiomyopathy, kind of an abnormality of the heart muscle. And in some individuals, if it's not caught, it can lead to heart failure, where the heart again is not pumping normally. And it depends on what specific agent. So, depending on what kind of chemotherapy you may be receiving, you may not need any follow-up with the heart. But if you are on certain agents, and it's a good question to ask your oncologist, then you will need an echocardiogram initially, which is a sonogram of the heart. And that will tell us about the heart muscle itself.
Do low oxygen levels relate to heart disease?
It relates more to lung disease. It can reflect, we do walk tests, for some patients who have very severe heart disease and often are on the transplant list, we do a walk test and we may determine oxygen levels, and it may kind of help determine what your level of fitness is, but it's more of a reflection of lung disease. So I wouldn't use that as a basis, for kind of determining heart disease.
What is your take on social stress to include anxiety for Black women being dismissed when concerned and or reporting symptoms?
So women in general, we are, we walk into the emergency room again, up through the 1960s, heart disease was just thought of as a man's disease. So we often have to advocate for ourselves. And oftentimes we'll go into the ER and they don't look at the heart. They may say, well, you just have maybe having a little bit of a panic attack, go home. Usually they will do an EKG, but it often is dismissed. And we looked at some of kind of the treatment and kind of differential treatment, even among healthcare providers to women. So it's important for you to advocate. If you know you're not feeling well, if you were able to walk up 2 flights of stairs and now you can't, you want to be an advocate. You want to say, you know what, I want to make sure it's not my heart. And what can we do to ensure that? And so being proactive about it is important.
Can you repeat what signs for a heart attack women should look out for?
So an immediate heart attack, some can be silent, so you may not know you're having one. And those are quite dangerous because you just don't know what's happening. But oftentimes you will have, if you're having an immediate heart attack, you will have some symptoms that will be sudden, such as a sudden onset of chest pain or sudden onset of perspiration, profuse perspiration, or shortness of breath. And there could be other reasons why that's occurring. It's not just the heart, it can be other disease processes that lead to that, but kind of a sudden change at all, you want to make sure to call 911. Now, small changes that you notice over time, let's say shortness of breath, or if you're walking down the block and you start to feel a little bit of funniness in your chest, but it doesn't stop you in your tracks and you're able to go forward, and you notice it the next week as well. Those are what we call angina symptoms, or symptoms where your body may be telling you that you have underlying heart disease. So if you start noticing those symptoms over time, you need to, again, we're wearing all different hats. So we're taking care of our kids and our parents and our spouses, but you have to say, wait a minute, this is different. And I want you at that point to call your doctor and be evaluated for any evidence of heart disease. But a heart attack, it's you picking up the phone and you're dialing 911. And also with stroke. So if you're home or if somebody's home and there's a slurring in speech or there's any weakness on one side of the body, you want to get into the hospital, because if we can get that oxygen or that blood flow back through that vessel, that's going to be key.
All right, these two questions are very similar. Both persons are on blood pressure medication, and they're asking that if their blood pressure is within the normal range or it's staying low, can I take myself off or lower my medication if my doctor will not?
No, we just can't do it ourselves. Now, a lot of times we want to be off the medications, but that's going to take some work, and that's going to take working on your part and along with your doctor. But I would say, if your doctor is saying you still need to be on these blood pressure medications, and you have autonomy, you can do what you please, but I would not recommend you saying, well, I'm not going to take it. Because again, that silent killer, that's going to be working on our blood vessels and pounding against our blood vessels. So even if you're monitoring your blood pressure at home and you find that your numbers are getting better and you think you can come off your medication, that's great. Or if you've lost a lot of weight, if you lost even a little bit of weight and you can come off, that's a discussion to have first with your primary care physician to see if that's the right decision for you. But I would not recommend stopping on your own.
Is it possible to reverse heart disease?
Some types of heart disease, yes. So coronary artery disease or blockages of the heart, oftentimes we can't reverse. There were some studies showing there's maybe some mild reversal and some of the plaque that builds up. But in general, if we have the plaque there, it's there. The good news is that we can stabilize that plaque so it doesn't, progress. And so a lot of times we may need further medications for that. So there are a lot of medications that can work to help stop things in their tracks and not help us progress. There are certain types of heart disease that can be reversed. For example, if somebody's a heavy drinker, they can develop heart failure or a dilated heart failure. And so if that person stops the heavy drinking, a lot of times we'll see that heart muscle reverse. And a lot of times we may get a virus, kind of like COVID-19 or other viruses that can cause a myocarditis or an inflammation of the heart, and it may not work well for some time. And that can be reversed in time, depending on what caused it. So yes, there are some types of heart disease that can be reversed, but it's, there are specific types.
Can you recommend vitamins for heart health?
Good question. So, there have been a lot of studies looking at different vitamins and its relationship to heart health. Some studies that found a positive effect, some studies that found no effect. Generally, right now, we're not kind of recommending particular vitamins for heart health. I think, the main thing is to get your vitamins from your food, and eating a healthy diet. Fruit and vegetables are going to help you get all the necessary nutrients you need to keep your heart healthy.
All right. Thank you so much. We are at time. Thank you again, Anjanette, for sharing all of your expertise with us this afternoon. For our participants, we thank you for joining, and please visit the Eastern Area Links booth. We will be uploading Anjanette's presentation shortly following this session, and we also have other materials there focused on heart health for you. Thanks for joining us, and enjoy the rest of the summit.
Thank you.